Hello everyone, this is Alraies and this is SIF 2021. With me is Dr. Morton Kern. He is the Professor of Medicine at UC Irvine as well as Chief of Cardiology at VA Long Beach. Dr. Kern, thanks for being here.
Hi, thank you, Chadi.
It's nice to see you in person.
A pleasure.
And finally shake hands and everybody's vaccinated. Tell us about the change in the conferences, and the teaching and education that happened during COVID era and how we're going to transition back to life.
Yeah, so in brief, and I think everybody knows that conference meetings stopped. Personal interaction stopped, distance and spacing and masks put an end to face-to-face. So we went Zoom. All the university teaching lectures went to Zoom format. Zoom format is okay, you can convey it, but it's hard to get feedback and it's hard to go both ways. So it lost its personal touch,
Yes.
It lost the stimulation of fellows,
Yes.
It lost the humor, and it lost some of the flow. So those were substitutes. And now after all this time, the disease is getting better, under control. We're vaccinated, all the healthcare providers and fellows and staff, faculty are vaccinated. We still mask, we still separate because we don't know who's going to carry what variant. But this SIF is the first live hybrid meeting where there are people that come in via Zoom, but mostly we're live. And masks are still there, spacing's there, hand washing and so on, protection, but most everybody is vaccinated.
Absolutely.
Not all, but every. And I think the interaction of human conversation,
It's very important.
contact, seeing face-to-face, even with masks on, is critical to the transmission of information. It is the whole experience. It embeds it back. The knowledge gets soaked in better.
Absolutely.
And so there's just no replacement for live meetings.
So, just a question crossed my mind about the trials and recruitment.
Yes.
So there was a pause for a year.
Yeah.
Do you think that will obviously delay the recruitment, but how this going to affect future therapies and treatments?
I think the delay in study results and study performance is part of the pandemic.
Yeah.
It's just one of the side effects. It'll come back. It'll just move it forward in time.
Yeah.
I don't think it will change the way we do business, but I do think that telemedicine is going to come in at a bigger role. Consultations, our video voice consultations are better.
Absolutely.
And for the veteran population, this is very popular. And I think it's going to spread. So that will be a permanent change. But for the medical education, we'll go back to conferences. For research, you still have to contact the patients, and the analysis and recruitment and so on will all just be slower to return, but it'll come back.
Speaking of science, you presented today IFR, post-PCI, defined PCI, and future defined GPS.
Yes.
So tell us about post-PCI FFR.
Okay, so you know the challenge in physiology for interventional cardiologists is to stop for a moment and assess whether, before we do anything, that lesion really needs it. Okay, I'm going to set that aside because that's a battle that we should have won and hopefully will. Now we're doing the procedure. We want to give the very best results.
Yes.
And we know if we guide it at the end of the procedure, knowing that our FFR has been restored, this is after checking the stent, we restore the physiology, either IFR or non-hyperemic pressure ratios or FFR, we can reduce the event rate. You know, we can move it from, get a better 10% outcomes.
Yeah.
So the idea is, who's going to stop and measure post-procedure physiology? Do I care for a 10% better outcome? Well, the answer should be absolutely yes. Mm-hmm. So what should we use? Well, if we worked on a pressure wire, we have the answer. If we worked on a regular wire, we could use a microcatheter. Yeah. If we have a system of angiographically derived FFR, like QFR or VFR or angio-FFR, then we could have that information as well. And I think the future is moving from a wire FFR to an angiographic FFR, but getting the end physiology the best we can. Don't leave no lesion behind. Make sure that diffuse disease is documented, and make sure we didn't miss a proximal narrowing or any kind of edge stent event.
Absolutely. So how I can reconcile ultimate findings, which is post-PCI IVUS, with physiology? Is there a percentage of patients with well-opposed stent but still physiologically compromised vessel?
Yes, absolutely. So the stent is only one part of the makeup of the entire physiology of the vessel. So let's look at the stent. If you have a stent that's well opposed and there's no edge dissection and there's no material proximal, then the IVUS will give you the information. But what about a centimeter distal? What about the diffuse segment of disease? What about the lesion that was on a bend around a curve that you didn't see while you were working, and now your wire detects it? What about the proximal disease near the guide, which you called guide catheter damping, but is really a lesion? And so a co-registered pullback through the vessel at the end of the procedure will tell you, one, diffuse disease, hidden focal, through the stent, whether it's well opposed and all that issues with stent are done, and was there any technical error in terms of drift or other kind of signal error. And you'll have that all on a pullback. But co-registered is the key, I think, to have it anatomically located to where we are. And even IVUS, I think, should be co-registered.
So as you said, to recap, is IVUS is great for the work you have done on that segment only,
yes,
but still physiology is the ultimate answer.
Yes, it's the screening for have you finished your work.
Yeah. And you presented also about diffuse versus focal.
Yes.
Focal fix, diffuse medical therapy.
Yes, so if you have diffuse disease in a vessel beyond the stenosis and your FFR is lower, you have to make a decision. I mean, where do you start and where do you finish in a diffuse vessel, right? I mean, you could put metal through the entirety of it, but the patient won't do much better.
Right.
And so I think that the pullback where you see a big change in pressure gradient is a focal area, and that can be addressed. And again, if you started with an abnormal FFR, you stented, and your FFR is not much better, something's wrong. And you don't want to leave the guy with residual FFR.
You did nothing there.
Otherwise, you failed in your mission.
Yes.
And so the idea is to make the patient better.
And you show us phenomenal algorithm of how to approach it, if it is normal, abnormal,
yep,
by the paper from Korean
yes,
researcher.
Wang. Just
Wang.
came out last week, I'd say, or
yeah,
2 weeks
March,
ago.
yeah.
Right.
Yeah.
And it talks about final FFR high, you're good to go. That's already provided your IVUS stent work was done. FFR low, why? Is it a technical issue on the pullback? Is it drift or some other issue? Or is it focal or diffuse? If it's diffuse, you have to decide how diffuse and should I attack it? Or if it's focal, where and should I re-stent it, put another stent in?
Absolutely.
So it's a fairly straightforward algorithm.
It's a matter of dropping the pressure wire again or working with the same wire to fix the...
Exactly. So we have tools. We have great wires now, great pressure wires. And I think the days of saying, oh, I can't work with the pressure wire should be over. Yeah. I mean, I'm the wrong guy to ask, but modern interventional cardiology should employ physiology and intravascular anatomy through IVUS or OCT on a majority of cases. There are a few cases where you don't need these.
Absolutely. Well, Dr. Kern, always a pleasure to talk to you and teach us about all IFR and imaging. Please watch this video and others on SIF YouTube channel. This is Alraies from SIF 2021. Dr. Kern, thank you.
Thank you. Thank you all.